I'm starting. Okay. So I've started with general pathology today morning because you can literally listen to the background music basically. So it's a lot of noise. I mean that Kachra Gadi song has come. So no one would want to hear that. So I'll just display that and I'll keep the audio muted, and whenever the sound, I mean, there's going to be no background music like this. I'll just unmute and start talking. So just look at the image more on this page rather than all the text. Okay, so it's quite silent. The thing is, this audio issue as in the background music of all the honking, but now it's not even the honking. They come with the, rubbish bin and keep on singing the Kachra Gadi song, okay, till 11 o'clock. So that's why, just bear with it. But then now it's silent, so I'll just go ahead quickly. See, cellular reversible, okay, all this not very necessary. LV hypertrophy is injury to myofibrils, and that's why you have HF, heart failure. Next, hypertrophy, puberty, pregnancy. Okay, see, puberty and pregnancy, you have both. Okay, in autonomous hyperplasia, fibromatosis is an example, and obviously, pregnant uterus is hypertrophy, and compensatory is going to be liver region, and so on. Now pathological hyperplasia, endometrial hyperplasia, endometrial this thing, endometrial cancer. Next, gyri, sulci, ventricles, pulmonum, this are all brain atrophy features, and brown atrophy of the heart. This is very important. So increased cytoskeleton degradation in case of atrophy by the ubiquitin proteasome pathway. So this gives rise to the brown atrophy of the heart. Okay, this gives rise to the brown atrophy of the heart, and lipofuscin granules is formed, and this thing metaplasia, reprogramming of the cells, and most common metaplasia is squamous. And in case of respiratory, this is a very important thing to note, that you basically have the tobacco smoke is converting the ciliated columnar into squamous. Okay, and in case of Barrett's, it's always adenocarcinoma, and connective tissue myositis ossificans, heterotrophic calcification. So calcification type important: heterotrophic. Okay, next, dysplasia, increased mitotic figures, irregular nuclear borders, low maturation index. Features of dysplasia: disordered precancerous epithelial growth, not considered a true adaptive response. Pleomorphism, when the cell and shape size changes. Increased nuclear cytoplasmic ratio, cum chromatin, do not involve the entire thickness. Okay, and next is carcinoma C2, persistent metaplasia, and yeah, carcinoma. This is important. Mm, this is very important. Dysplasia occurs in metaplastic epithelium, but all metaplastic epithelium is obviously not dysplastic. So dysplasia can be a part of metaplasia, but not always. So what can lead to dysplasia? Two things leads to dysplasia. One is persistent metaplasia, and one is pathological hyperplasia. So these are the two things leads to dysplasia. Hyperplasia is number, hypertrophy is size, trophy is size. Okay, next the atrophy is number and size, and the cell cycle and all this. This is reversible change. This is irreversible change the moment it goes into neoplasia. If the structure and the cell type is changing, then is metaplasia, and if the structure is changing, then is dysplasia. Okay, so this is important for NEET. Next, cell injury. Cell injury, cytosolic calcium increase figures. Myelin figures reversible में irreversible, it is clumped, large. Okay, and main thing is this diagram is important. Okay, so diagram is more important than the text itself. First, let's see reversible. So normal, reversible. We have decreased ATP. Now decreased ATP only gives rise to everything. Decreased ATP, decreased calcium, sodium potassium pump. Because of non-functional sodium potassium pump, we have cellular mitochondrial swelling. Okay, that is the first sign. So first sign, cellular mitochondrial swelling. Fatty changes is first sign on light microscopy. Fatty changes first sign on light microscopy. For reversal syringe, next is ribosomal protein obviously detaches, so that's why there's less of protein synthesis. Plasma membrane, we have blebbing. Nuclear changes, chromatin clumping. Rapid loss of function myocarditis is non-contractile after 1 to 2 minutes of ischemia. Okay, one non-contractile. Myelin figures, electron microscopy, myelin figures. We have peroxidized lipids, important. Reversible cell injury, electron microscopy findings, myelin figures, aggregation of peroxidized lipids, and we usually have a phospholipid wall, cell, and mitochondrial membrane damage. Okay, so myelin figures, aggregation of peroxidized lipids, phospholipid wall, cell, and mitochondrial damage. Fatty changes, first light microscopy finding that is seen in reversible cell injury, and first morphological finding is seen in cellular swelling. Okay, next is irreversible chain. So we have irreversible chain. Breakdown of the plasma is cytotropic, all the enzymes it leaks out. Mm, Activation degraded enzymes because of calcium influx. ATP is okay, decreased ATP. So mitochondrial increase in mitochondrial permeability. That's why ETC is lost, and there's decrease of ATP. And the enzyme that does it, ATPase. So which are the enzymes? We have ATPase doing mitochondrial damage. We have protease and phospholipase goes for lysoautolysis. Nuclear degradation, pycnosis. Nuclear cardiorexis, nuclear rexis of fragmentation, caused by endonuclease mediated cleavage, and finally cardiolysis. So rexis, lysis. Nuclear concentration, protein fragmentation, and finally nuclear dissolution. Next, that is on endonuclease. So ATP is protease, phospholipase, endonuclease, and electron microscope finding. Before it was what? Myelin figures with peroxidase. Here is amorphous densities, including the mitochondria. Myelin figures more in irreversible than in reversible. Done. Great. And we also have hydropic changes in reversible. Okay, next we have apoptosis. Okay, so apoptosis, let's see. In this, basically, wait just a second. Okay, so glucocorticoids apoptosis inducer. Um, okay, glucocorticoids are basically apoptosis inducers. So ATP dependent, this is very important, very important. ATP dependent program cell death, intrinsic activation pathway, both of them. Caspases activate caspases at the end. Activate caspases cytosolic proteins. The caspases cytosolic proteins. Okay, no cell swelling. Obviously, the membrane is intact in case of apoptosis. Membrane intact in case of apoptosis. Okay, so breakdown including cell shrinkage, okay, shrinkage, condensation, blebbing, apoptotic bodies, phagocytized, and deep eosinophilic cytoplasm, deep eosinophilic cytoplasm, basophilic nucleus, pycnosis, karyorrhexis, and wait a second, let's see, okay, okay, glucocorticoids was the inducer, done. Cell shrinkage, all this is done. Now we'll go to the pathways quickly. Deep eosinophilic cytoplasm, okay, proteins destroyed, deep eosinophilic cytoplasm form because proteins are destroyed. So eosinophilic cytoplasm is due to proteins destroyed, and basophilic nucleus, and you get pycnosis. So there was what pycnosis, karyorrhexis, and karyolysis. Cell membrane typically is intact with a significant inflammation. Okay, calcium dependent endonuclease, DNA laddering. This का photo very important. Calcium magnesium dependent endonuclease DNA laddering, fragments in multiples of 180 base pairs, sensitive indicator of apoptosis. DNA laddering, fragments of multiples of 180 BP. Okay, DNA laddering, we'll come across it. Intrinsic mitochondrial pathway, embryogenesis, regulating factor withdrawn from a cell. When regulating factor is withdrawn, interleukin 2 it decreases after immunological reaction. So apoptosis, proliferatory effector cells, injurious stimuli, or this thing, either regulatory or this thing, interleukin 2 or exposure to radiation, toxins, and hypoxia. Okay, so as usual, this is extremely important. Stress sensors. Okay, stress sensors is BIM, and BAD. Okay, so we start with first BCL2 family proteins, BH1 to 3, that is BAX, BH1 to 3, uh, that is BAX and BAX pro-apoptotic. Okay, BAD, BA, all BA is pro-apoptotic. So BA and BA is all pro-apoptotic, so bad for survival, bad. Okay, smack diablo is also pro-apoptotic. BH1 smack diablo, BH1 to 3, back smack diablo, BH1 to 4 domain, MCL1, BCL2, BCLX2, BCLXL, and these are anti-apoptotic. So bad and backs back. Okay, that's and smack diablo. So ac, everything that is ending with the ac, that is back, smack, diablo. All that is bad for survival. That is low apoptotic. 1 to 3, and MCL, XL, all anti-apoptotic. CL is all anti-apoptotic. How is okay? Back, spores, mitochondrial membrane, cytochrome C is released, and caspase is activated. BCL2 keeps the mitochondrial membrane impermeable. BCL2 overexpression. Follicular lymphoma, follicle for say 14, so 18. Decreased caspase activation, tumorigenesis. And what are the stress sensors here? Okay, BIM bit bad is BH3 Puma and Noxa, AA, Puma Noxa, and that side everything that is ending with back, that is back, smack, means basically the pronunciation is ack. Okay, so ack is bad. Okay, so backs bad, back, and smack and diablo, and cl, mcl, bcl, uh, mcl, bcl, bcl xl, bcl2 also, all this, and t. Okay, next is two pathways, fast cd95. Okay, fast ligand, pipeline, and fast is cd95, cd95. Okay, say 95 years old now, it's gonna die. Okay, tnf alpha binding to the receptor, TNF alpha binding to the receptor, TNF alpha. TNF alpha facile ligand necessary for thymic medullary negative selection. Thymic medullary negative selection. Thymic medullary negative selection. Defective Fas ligand interaction. Failure of clonal deletion. So defective Fas ligand, failure of clonal deletion, increase in self-reactive lymphocytes, and you have autoimmune lymphoproliferative. If you have defective, because then this negative selection will be failed and there will be problems. Now this diagram is important. So this is the very this thing where extrinsic cell pathway is basically not not working. So that is thymic medullary negative selection. Then it causes autoimmune lymphoproliferative syndrome. Now this, okay. So first is we have the intrinsic and extrinsic. Intrinsic is obviously DNA damage, any kind of hypoxia, misfolded proteins, etc. P53 gets activated. It activates the apoptotic protein back smack diablo. This forms pores in the mitochondria, and you have cytochrome C, APAF complex, apoptosome. Okay, all these people, they activate the initiator caspase 9. Okay, always initiator caspase 9. The 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 negative means prevents mitochondrial permeability to go too much. This is prevented by BCL2, BCLXL, MCL1. Okay, those are the sensors. Cytochrome C, that will come out. Cytochrome C, APAF complex, apoptosome, initiator caspases. Initiator caspase execution है 367, 367, 367. Um, facile ligand CD95, TNF alpha initiator 810. So this is 9. And where's the 810? 810 and 36. So 3, 6, 7, 8, 9, 10. 3, 6, 7, 8, 3, 6, 7, 8, 9, 10. Cell shrinkage, chromosome condensation, cell shrinkage, chromosomal condensation, and then cytosolic nuclear fragmentation. And finally, phosphatidylserine. Yeah, this is another change, important change in apoptosis. The phosphatidylserine that was inside, that basically comes outside and forms ligands for macrophages to come and apoptotic body, eat up the apoptotic body. Okay, the phosphatidylserine helps to means eat up the apoptotic body. In case of this, another very important fast, and when fast ligand it forms fast death domains and converts pro caspase 810 to activated caspases. Another flip flip inhibits extrinsic and is a caspase antagonist. Flip annexin 5 is apoptotic marker. Annexin 5 flip, it inhibits extrinsic caspase antagonist. And councilman bodies, all this has come in NEET. Councilman bodies, and sometimes maybe in INI also. Councilman bodies, acidophil bodies, apoptotic hepatocytes, acute viral hepatitis. So councilman body acidophilic. Image is important, and acute viral hepatitis cells will maintain the outline, shrinks, but outline is maintained. Plasma membrane intact pyknosis. Oh god. Okay. Next is Mallory Denk bodies. That's going to be alcoholics. And DNA electrophoresis, step ladder, and Apoptosis, we had a step ladder in apoptosis, and there was smearing in case of necrosis. Caspase's full form is cysteine aspartic proteases. Cysteine aspartic proteases. Maladie-Dengue bodies is alcoholics. Acute viral hepatitis, councilman bodies. And caspases, cysteine aspartic proteases. Cystic aspartic proteases. DNA electrophoresis, apoptosis, smearing is seen in this. DNA laddering because the endonuclear antibiotics, this thing. Okay, apoptosis, so that is done. Next is necroptosis. So necroptosis, it's an MLKL phosphorylation caspase independent process. Programmed necrosis, caspase independent, so not apoptosis. Programmed necrosis, TNF-R1 forms TNF alpha. You have RIP1, RIP3 kinase necrosome decreases cellular ATP and causes necroptosis. Alcian blue mucicarbamide stain, it's used for necroptosis. Efferocytosis is phagocytosis of apoptotic bodies. What does it need? Phosphatidylserine. Dendritic cells, macrophages, and fibroblasts. And then finally we have agarose gel electrophoresis. So another one, pathological, when we have ischemic brain injury, neurodegenerative viral. Okay, this is pathologic apoptosis. Physiologic apoptosis, mammalian bone growth plate. Blebbing or the cytoplasmic, these differences are fine. Clearance apoptotic phagocytose, then this is not going to be this thing. This is all viral exposure and so on. So caspase independent necroptosis, TNF alpha, RIP1, RIP3 kinase necrosome decreases cellular ATP, MLKL phosphorylation, programmed necrosis, TNRF1. This is important. Just come DNA. Okay, so step ladder pattern is apoptosis and smearing is necrosis. So diffuse smoothing, oligonucleotides in a 15 to 300 base pair step ladder pattern, cleavage between nucleus and subunits, and in case of normal cell, no clearing. Next is necrosis. Just a second. Necrosis, sensory influenza rexis lysis, cardiorexis cardialysis, and nucleocyte moth-eaten vacuolated cells, glossy, homogeneous, glycogen loss. Glossy, homogeneous due to glycogen loss. Moth-eaten is due to that vacuolated structure. Exogenous injury, Plasmid damage, cell injury undergoes enzymatic degradation. Enzymatic degradation, denaturation, local inflammatory reactions, unlike apoptosis, passive process. Denaturation, passive process. Next, coagulative necrosis. Okay, so just differences between these two. Coagulative is tombstone, moth eaten, which can in fact except brain. Okay, even Zenkos and thermal injuries. So liquefactive is seen in brain. Everywhere else it's coagulative in case of ischemia, but liquefactive is seen in brain. Brain infarcts lipid rich. Why? Why liquefactive? Because brain infarcts are lipid rich. Brain infarcts lipid rich, so that's why. Next, obviously coagulated denatures enzyme therefore rises, therefore it is blocked. Okay, and finally the removal is by phagocytosis. But here it is the neutrophils that release microglia. Microglia was mesenchymal lysosomal enzymes. It's secreted mesenchymal enzyme. Early cellular debris macrophages, late cystic and cavitation. Neutrophil cellular debris, similar bacterial infection, caseous necrosis, TB, systemic fungi, histoplasma, nocardia, coccidiomycosis. Macrophages wall off the granular debris. Cheese-like cross appearance, giant cells. Lymphocyte macrophages mainly. Granuloma, necrotizing granuloma. Next, fat. Fat enzymatic acute pancreatitis, saponification, and peripancreatic. Momentum fat and peripancreatic fat. Non-enzymatic lipodystrophy. Non-enzymatic lipodystrophy due to repeated insulin injection, traumatic. Okay, so this is non-enzymatic. And enzymatic is obviously saponification, acute pancreatitis. Damaged pancreatic cells release lipases, triglycerides. Lipases which break down triglyceride, liberate fatty acid. Calcium causes saponification, dark blue on HNE. Pancreas momentum breast. Pancreas momentum breast. Outlines all that not necessary. Fibrinoid. Okay, so the images A is reddish pink color. That is going to be preserved architecture in case of coagulative necrosis, increased eosinophilia. So that is it. B, obviously cellular. This thing digest liquefactive necrosis is B. C is caseous necrosis. D is fats. Okay, HNE staining dark blue. Okay, so D, HNE staining dark blue. Okay, next is fibrinoid necrosis. The seen in pan polyarthritis nodosa, non-immune vascular reaction, emergency hypertension, management hypertension, fibrin leakage. Okay, type 3 hypersensitivity. Very important. Type 3 hypersensitivity, that's why immune complex deposit. Type 3, fibrinoid is type 3. Just make it an E. So then you'll get 3 if you make it an E. Okay, if you make this an E. Eosinophilic layer, violaceous mass. Okay. Pass is going to be red. Okay, so pass stain. Gangrenous distal extremity, GI tract, cornica. Dry gangrene is coagulative. Wet gangrene is liquefactive. Wet gangrene liquefactive superinfection. Coagulative ischemia. Pyroptosis is infected cells, stimulates inflammasome, which in turn stimulates caspase 1 interleukin 1. Caspase 1 interleukin 1. And acidosis is Rick. Ischemia. This one is nice and simple, but doesn't always come. But then, simple subendocardium, all the watershed areas, ACMCA, straight segment of the proximal tubule, thick ascending limb, zone 3. Splenic flexure is Griffith's point, and rectosigmoid junction is Sudek's point. Rectosigmoid junction, Sudek's point. Hippocampus 356, neocortex, hippocampus 356, Purkinje cells. Okay. Red infarct, pale infarct, important. Okay. Red infarct, venous occlusion, that was zone 3. Okay, central vein, zone 3 of the liver. Zone 3 of the liver. Central venous occlusion, tissue multiple blood supplies. Venous occlusion, tissue multiple blood supplies with reperfusion after reperfusion injury. So reperfusion injury, red infarct, venous occlusion, multiple blood, reperfusion injury, free radicals. Okay, this is A. Red infarct. Next is pale infarct. Solid organ, single end arterial blood supply. Single end arterial blood supply. Red infarct, multiple arterial supply. Uh, Pale infarct is single end arterial blood supply. Kidney, heart. Free radical injury, membrane deposition, protein modification, DNA breakage. Phase 1 of the drugs. Metabolism of phase 1 drugs, redox and nitric oxide. WBC neutrophils and the scavenging enzymes, catalase, superoxide dismutase, glutathione peroxidase, vitamin A, C, E, antioxidants, ACE, just ACE it. So ACE. Okay, let's ACE the exam. So ACE and transferrin cellular plasmin. Okay, next is oxygen toxicity, retinopathy of prematurity, acetaminophen overdose. This is a past year. Without me saying only that acetaminophen overdose and this. Okay. Retinopathy of premature bronchopulmonary dysplasia, repurposition of the thrombolytic therapy, acetaminophen overdose, hepatotoxicity. It forms that NAPQ. I think so. It was in this only. Carbon tetrachloride. Carbon tetrachloride, cytochrome P450, CCl3, free radical, fatty liver to the injury, fatty liver cell injury, decrease apolipoprotic force, centrilobular necrosis, centrilobular, metal storage, Wilson, all this is free radical, Wilson's disease and hemochromatosis. Okay, carbon tetrachloride, remember this is only carbon tetrachloride, P450, acetaminophen overdose. Radiation injury is very important. Okay. So rapid. Okay, actually this entire thing is important. Ma'am has also given it. Okay, so this is there in radio. This thing also, radio BTR and stuff. So ionizing cell radiation damage. Okay, remember which damage? Pyrimidine dimers. Okay, rapidly regenerating tissues, skin, epithelia, bone marrow, GI tract, GU, gonads, most susceptible. Okay, bone marrow is actually the most susceptible, more than the gonads. Bone marrow, skin, hair loss, erythema, desquamation, skin ulceration. Hemopoietic is myelosuppression. Gastro is abdominal pain, bleeding, GI tract. Neurovascular is papillary edema, seizure detection, impaired reflex or cognitive deficits. Acute, this is full exposure when you have acute radiation syndrome, erythema. Partial exposure, just local toxicity of skin, gonads, and eye. Blister, sterility, decreased sperm, and cataract. And late complication is fibrosis. Radiation fibrosis and radiation induced malignancies. Very, very important. Okay, so skin, subcutaneous tissue, those are induration, thickening, losses, shrinkage, lymphedema, lung, pulmonary fibrosis, head and neck, trismus, mucosal fibrosis, ulceration and fistula, obstruction in case of gastrocnemic symptoms, ulceration, fistula, genitourinary urethral stenosis, obviously fibrosis, stenosis, fibrotic bladder constriction, esophageal, vulvovagina, ovaries fibrosis, obstructive uropathy. Radiation includes malignancies is the most important. Thyroid, papillary, okay, papillary thyroid carcinoma, orphan annii nucleus. Remember, orphan annii nucleus was in papillary thyroid carcinoma. And Samoma bodies. Everything papillary has Samoma bodies. Okay. Next is hemopoietic. This thing is myelodysplastic syndrome, lymphomas, and leukemia. CML, ALL, CML, ALL, AML, and skin angiosarcoma. Bone is osteosarcoma. Osteosarcoma. That's why this is radio resistant and chemo resistant. And I think we are doing surgery in this. Differentiate it with. Um, Ewings. Okay, others solid tumors like breast, ovary, and lung. So radiation related malignancies, thyroid, papillary, hemopoietic is CML, AML, ALL, and myelodysplastic syndromes, lymphomas, skin, angiosarcoma, osteosarcoma in case of bone. Okay. Types of calcification. Extremely important. Extremely important. Okay, lipofuscin we had seen up also. Okay, this was there before in hyperplasia, ubiquitin proteasome pathway. Okay, next calcium calcification. So calcification, calcium to appear to be deeply basophilic. Deeply basophilic. Von Cossa stain is dystrophic calcification. Von Cossa stain. Dystrophic calcification is von Cossa. K for calcium, K for Cossa. Cossa calcium. Okay, sounds very similar. So calcium deposition where it is, and metastatic calcification. So let's do difference wise. Calcium deposition, here it is all the dead and dying tissues abnormal, here it is all the normal tissues का बैंड बजा देता है. Okay, next is extent. This is localized calcific aortic stenosis and so on. This is widespread, diffuse metastatic and so on. Okay, diffuse metastatic, like how you can have in breast or breast carcinoma. Okay, then where else, blastic lytic metastasis, prostate carcinoma. Okay, so associated conditions, now see TB, lung, pericardium, other granulomatous infection, liquefactor necrosis, chronic abscess liquefactor necrosis. Where it happens the most, that is brain. Fat necrosis, we had saponification, all that. Infarcts, thrombi, schistosomiasis, congenital CMV. Okay, congenital CMV, very important topic for INI. Okay, so congenital CMV, toxoplasmosis, rubella, Samoma bodies, Crest syndrome, very important. Atherosclerotic plaques, all of this becomes calcified. Schistosomiasis, bladder cancer, calcific valvular stenosis, and even this Monkeyberg medial sclerosis. This is malignant. It is all in hypertension. So Monkeyberg medial sclerosis, calcific valvular stenosis, atheromatosis plaque, Samoma bodies, congenital CMV, rubella, schistosomiasis, fat necrosis, infarct, chronic abscess liquefactive necrosis, TB, lung, pericardium. Next, this one. Metastatic calcification, interstitial tissues of kidney. Interstitial tissues of kidney, vasculature. Interstitial tissues of kidney, the vasculature, gastric mucosa, and lungs. Increased pH favors calcium deposit, nephrocalcinosis. Collecting ducts, nephrogenic diabetes insipidus. No, morphine increases the nephrogenic, 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 nephrogenic collecting ducts, they may lead to nephrogenic collecting ducts can lead to diabetes insipidus, and finally renal failure. Nephrogenic, nephrogenic collecting ducts, nephrogenic collecting ducts, nephrogenic diabetes insipidus. Sorry, nephrogenic collecting ducts. I'm saying nephrocalcinosis of collecting ducts. It can lead to nephrogenic diabetes insipidus and renal failure. Etiology: this is secondary to necrosis. Obviously, we saw that above, liquefactive necrosis and so on. And this is secondary to hypercalcemia, malignant hypercalcemia, where we can have primary hyperthyroidism, hypercalcemia, sarcoidosis, sarcoidosis. See, that side is other granulomatous infection, but here is TB. But here you have sarcoidosis as well. Okay, hypervitaminosis D. Okay, or high calcium phosphate product level. Okay, see all of this. And chronic kidney disease, secondary hyperparathyroidism, secondary hyperparathyroidism, primary hyperparathyroidism, sarcoidosis, hypervitaminosis D, high calcium phosphate, chronic kidney disease with secondary hyperparathyroidism because of you have phosphate retention in this case, long-term dialysis, calciphylaxis, multiple myeloma, hypercalcemia of malignancy, Paget's disease, increased bone catabolism. This is usually abnormal, but this can be normal. Lipofuscin, yellow brown wear tear, normal aging, endogenous pigments, lipid peroxidation of polyunsaturated lipids, polyunsaturated, polyunsaturated lipids, PUFA, brown atrophy of the heart, autopsy laterally will reveal that, colon, liver, kidney, eye, and other, golden brown nuclear pigments, perinuclear pigments, no venules in the lungs, no venules are present in the lungs. That's what I had written here. Whatever. Mm, just let's go back and take a look at the this thing. What was this? Here, this was atrophy. So that's why aging, aging, brown atrophy of the heart, lipofuscin granules. It's mainly related to aging. Okay. So let's go to the next page. Amyloidosis, very important, very important, especially this pretty color. Okay, which looks like some kind of candy. Okay, abnormal aggregation of proteins. Okay, just a second. Okay, so the next thing is amyloidosis. Okay, so amyloidosis, it's just super important image based question. So make sure to look at the images very well. Okay, so we have abnormal aggregation of proteins or their fragments. So finally, amyloidosis is what? Abnormal aggregation of proteins into beta pleated sheet, insoluble fibrils, cellular damage, apoptosis. Okay, here. Amyloid visualize a Congo red stain red or a non-polarized light. Okay, so non-polarized light, apple green bifringence on polarized light. HNE shows deposits of glomerular. Acha, this is not a question mark at all. Now we know that this HNE is showing glomerular mesangial areas deposits. Tubular basement membrane enlarged on light microscopy. Fine. The tubular basement membranes. Next is, okay, this table is very important. Primary amyloidosis. Primary light chain AL, L for light chain. It is most common in kidney, more specific in heart. Most common kidney, more specific in heart. MM, okay, that is multiple myeloma. Plasma cell disorders. Secondary amyloidosis. Secondary amyloidosis AA. Okay, this is AL. This is AA, double A. Two times A, so that's why double A. So that's why it's secondary. Okay, interleukin 1, interleukin 6. Interleukin 1 was pro-inflammatory. Okay, pro-inflammatory macrophages secretes is secreted by macrophages and so on. Okay, uh, here this protein, amyloid A protein, so paraneoplastic syndrome, where all is seen in chronic inflammation, that was seen in plasma cell disorders, multiple myeloma, AL, light chain kinase. देखो light chain, whenever light chain comes, then obviously it's going to be multiple myeloma, more specific for the heart, most common for the kidney. Secondary, in case of secondary, you have interleukin 1 and 6, that is increasing. Proteins, chronic inflammation, rheumatoid arthritis, IBD, familial Mediterranean fever, protracted infection. Okay, these examples: rheumatoid arthritis, IBD, familial Mediterranean fever, protracted infection, interleukin 1 increases in familial Mediterranean fever, and there's also pyrin gene mutation. Because of that, you have fever. Paraneoplastic syndrome like in RCC and Hodgkin's, that also. Dialysis related amyloidosis, beta 2 microglobulin, ESRD long term dialysis. Okay, ESRD end stage renal disease. Manifestations include, for all the systemic amyloidosis, manifesting cardiac restrictive myopathy, cardiomyopathy, GI macroglossia, hepatomegaly, renal nephrotic syndrome, not nephritic, nephrotic syndrome. Okay, renal amyloidosis, restrictive cardiomyopathy, nephrotic syndrome, hematologic bruising and splenomegaly, neuropathy, and muscular carpal tunnel syndrome. Carpal tunnel syndrome. That's a end stage renal disease. You have carpal tunnel syndrome. It's important, very important. Okay, orange. All this is AIIMS. These additions are AIIMS. Okay, interleukin 1, pyrin gene mutation, and so on. Another, so mnemonics are AL, light chain, multiple myeloma, AL. Multiple myeloma, kidney is also affected with that. Interleukin 1 6, that is done. AA means 2. There are 2 times A, so that's a secondary. Secondary means 2. Dialysis associated DB, beta 2 microglobulin. Okay, so beta 2 microglobulin, DB. DB. Okay, next is localized. Okay, again Alzheimer's coming. Okay, so last time what had we read about Alzheimer's? In Alzheimer's, dopamine and acetylcholine. Okay, that was a difference kind of. Okay, so everything, I mean, it was decreasing. Next is I think dopamine is in, we have to go back and see those neurotransmitters, very important. Okay, beta amyloid protein. Okay, this is amyloid precursor APP. Okay, beta amyloid protein, amyloid precursor APP, type 2 diabetes mellitus IAP. So amyloid polypeptide. Now another this thing, beta amyloid protein. Okay, targeted antibodies against them is aducanumab and lecanemab. Okay, aducanumab and lecanemab. So amylin, pancreatic islets. Okay, so amylin and pancreatic islets. Amylin in pancreatic islets, you get in type 2 diabetes are obviously islet amyloid polypeptide. Medullary thyroid cancer, calcitonin, very important. Medullary thyroid cancer, calcitonin, worst prognosis. Okay, that's why in medullary thyroid cancer you have eosinophilic areas, amyloid stroma, calcitonin. Okay, and in medullary, and what did we have in papillary? Papillary was radiation induced. Papillary thyroid carcinoma was radiation induced, and it was what? Not only was it radiation induced, but also Samoa bodies. Or kya? You also get orphan annuli nucleus. And in case of medullary thyroid carcinoma, you have calcitonin. And see, this is so important that it's come in both. It's come in INI, and this has come in NEET as well. Okay, so Alzheimer amyloid precursor protein. Now by now I don't think I have to tell you. Okay, so amyloid precursor protein, that's going to be Alzheimer. This has come in INI, and medullary carcinoma thyroid calcitonin. It has come in NEET as well as INI both. Next, isolated atrial amyloidosis. Okay, so atrial, when you have, just think ANP. Okay, because atria is the one that is secreting ANP basically. So that is the compound, basically the fibril protein. Okay, these are the proteins that are defective here. Okay, next is ANP. Common in normal aging, atrial fibrillation chances is increased. Systemic senile age-related amyloidosis. Okay, systemic age-related wild type, normal wild type transthyretin. Okay, so this the mnemonic for this ma'am had said is wild Buddhe Baba. Okay, so wild Buddhe Baba, basically wild, normal, Buddhe, senile, and obviously so um, cardiac ventricles. Okay, there it was atria. As isolated atrial amyloidosis was atria, here it is cardiac ventricles. Cardiac are more insidious than AL amyloidosis. There in AL amyloidosis, what did we have? Restrictive. Okay, light chain kinase. Cardiac restrictive. Okay, so obviously it is more, the dysfunction is more because it is cardiac ventricles, senile. Next, finally we have, here we had TTR. Okay, wild type. Wild type, it is the normal transthyretin. Now see the difference here. It's all transthyretin mutated. Familial amyloid cardiomyopathy and familial amyloid polyneuropathies. Okay, so familial may, it's all always mutated transthyretin. Okay, in case of familial amyloid cardiomyopathy, you have ventricular endomyocardium. Which part of the myocardium is most responsible, most susceptible to ischemia? Endocardium. Okay, so ventricular endomyocardium deposition, restrictive cardiomyopathy. This was also seen in above. We also saw it in AL. And restrictive cardiomyopathy, arrhythmia. Okay, restrictive cardiomyopathy, arrhythmia is also here. We have atrial fibrillation as arrhythmia. Atrial fibrillation, sawtooth. Okay, not sawtooth. It's a very irregular baseline. Okay, and sawtooth was atrial flutter. P waves are still present in atrial flutter. 3 to 4% African Americans mutated allele. 3 to 4% African Americans have amyloid cardiomyopathy. And amyloid polyneuropathy में uses are this transthyretin gene mutation. Okay. Next, this difference of PMF and TRAPS, important. Familial Mediterranean fever, 3 to 5 days. Colchicine, FNFN, colchicine basically gives rise to familial Mediterranean fever and gout. While TRAPS, full form is TNF alpha receptor periodic fever syndrome, 7 to 10 days periodicity, drug of choices, steroids and etanercept. Okay, and colchicine is used in FNF as well as gout. Okay, etanercept. Etanercept is also used where rheumatoid arthritis, biologicals. Okay, so steroids, etanercept, drug of choice. 7 to 10 days periodicity. Okay, traps, TNF alpha. TNF alpha, TNF alpha, what was it involved in? Cachexia, cancer, inflammation, fever, heat. Okay, so TNF alpha. We'll come to the immunology, and then this is very well given in pixelize. Okay, receptor periodic TNF alpha receptor periodic fever syndrome, 7 to 10 days, 7 to 10 days periodicity. Steroids, etanercept, colchicine, FNF, gout, 3 to 5 days, familial material. Okay, on this page it's just inflammation response to cell injury, necrotic tissue removal, tissue repair, septic shock, prolonged if you have STB, inappropriate autoimmune diseases. So rubor, redness, vasodilation, everybody knows. Main thing is the mediators here. Okay, so this is what is quite confusing and plus difficult to remember also. So histamine is present at every step, to be honest. Okay, all of the steps will have histamine. Prostaglandin and bradykinin is present in first and third step. Okay, so prostaglandin and bradykinin is the, just remember B for bradykinin is the second letter, but it's not present the second this thing. It was not like basically Ruber, Caller, everything has, but only Ruber, Caller, and Doler. Okay, that will have PGE2 and bradykinin. Obvious, it's very obvious. These things are not going to cause swelling. So prostaglandin, bradykinin, PGE2. Remember E2. Okay, PGE2. Alright, and bradykinin. Next, in between, in case of tumor that is swelling, you have leukotrienes, C4, D4, E4, and serotonin. Okay, you remember we had serotonin. Serotonin was decreasing where? Okay, serotonin was decreasing in schizo. Okay, I think. Next is systemic manifestations, acute phase reactants. So fever, important, pyrogens, LPS, induced macrophages, interleukin 1, TNF. Okay, increase COX activity. Basically what happens is this LPS pyrogens, it induces macrophages which secretes interleukin 1 and TNF, tumor necrosis factor, which increases the COX activity in the perivascular cells of the anterior hypothalamus. Anterior hypothalamus was what? It was front part cooling, okay, anterior hypothalamus is cooling. Increase PGE2, increase temperature set point. So PGE2 is increasing, increase temperature set point. PGE2 not used for tumor, rest everything it is used for, along with bradykinin. Leukocytosis, WBC count is increased, and neutrophils, all this. Next is plasma acute phase reactant. This is important. Serum content significantly in this thing, produced by liver, induced by interleukin 6. Interleukin 6. Okay. Acute phase reactants. Very, very important. Very, very important. Okay. So ferritin sequesters iron, inhibits microbial iron scavenging. Okay. So prevents the microbes from taking the iron. Okay. So these are the things that are upregulated. You can remember the ones that is downregulated first is albumin and transferrin. Albumin reduction conserves amino acids and for positive reactants, and transferrin internalized by macrophages to sequester iron, internalized by macrophages, sequester iron. Alright. Next, ferritin binds sequesters iron to inhibit microbial fibrinogen, coagulation factor, endothelial repair, ESR correlates with ESR. More the fibrinogen, more will be rouleau formation, more will be the, lesser will be, faster will be the sedimentation rate. So fibrinogen, ESR, increase rouleau. Remember multiple myeloma. Serum amyloid A. Prolonged elevation can lead to amyloidosis. Hepcidin binds to ferroportin and prevents iron from coming. So iron release. So in decreased absorption by degrading ferroportin. Okay, decreased iron release from macrophages and causes anemia of chronic disease. Hepcidin. Haptoglobin, extracellular hemoglobin, protects against oxidative stress, binds to extracellular hemoglobin. Procalcitonin rises in bacterial infection. C-reactive protein opsonins. Okay, C-reactive proteins always increases. Remember COVID times, opsonin fixes the complements, phagocytizes non-specific sign of inflammation. Okay, next we have this. Where does ESR increase and where does ESR decrease? Okay. Okay, secondary amyloidosis, AA. That was AA. Okay. Next, erythrocytic sedimentation rate. So, RBC is normally said negative charge. Products fibrinogen coat, decrease fibrinogen coat. Okay, fibrinogen is coating this thing, decrease the RBC, increase the aggression. So that's why falls at a faster rate within the pupil. Dense RBCs falls at a faster rate, so that's why increased. Okay, so I made a mistake there. This is going to be increased. Okay, when it is going to coat and it is going to form rouleau faster, then it is going to increase ESR, but still I'll have to check this. Increase ESR falling at a faster rate, and co-testing with CRP, co-tested with C-reactive protein for specific markers. Increased ESR, faster sedimentation, erythrocytic sedimentation rate increases. That's what the rate increases. So it is faster, not the time. This is not a time, it is supposed to be a rate. Okay, sedimentation rate. So most anemias, we have infections, you have inflammation, giant cell temporal arteritis, polymyalgia rheumatica, cancer, metastasis, multiple myeloma, and renal disease, and pregnancy, and sickle cell anemia, altered shape. That is, it is going to decrease in polycythemia, less of this thing, dilute. Heart failure, microcytosis, hypofibrinogenemia, and finally sickle cell anemia. Next we'll go on to acute inflammation. Okay, I'll continue this in the next part. Okay, so we have already started off with inflammation, so the next part, inflammation, will be continued.